Ya, karena ini sesinya banyak ada pembicara dari luar, maka izin kami menggunakan bahasa Inggris. Good afternoon, ladies and gentlemen. Yeah, first of all, let me thank you still joining in the symposium today. The fifth session is a masterclass in interventional pulmonology. The purpose of this session is to deliver the knowledge of interventional pulmonology, especially EBUS-TBNA, Radial EBUS, and emergency bronchoscopy. We have three experts and international speakers: Melvin, MD, MBBS, MMed, MRCP farms, Shyang, MD, MRCP, and Daniel Tenda, MD, DIC, PhD. Each speaker will be approximately 25 minutes for presentation. After the presentation, then we have transition into question and answer discussion. So we have allocated 10 minutes for question and discussions. And then I will ask to our first speaker today, Melvin Chee, Kiang, MD, MMed, MRCP farms. Dr. Melvin is a consultant and acting director, Interventional Pulmonology, Department of Respiratory and Critical Care Medicine, Singapore General Hospital. He will be presenting on EBUS-TBNA. So please welcome Dr. Melvin Chee, Kiang. Time is yours. 25 minutes for presentation.
Okay, sorry for the technical glitch. Okay, good afternoon, everyone. My name is Melvin. Thank you, Mr. Chairperson, for the introduction. So I'm really happy to be here today to be sharing with you about this topic, which is quite close to my heart, which is EBUS-TBNA. So I'm going to break down the session into two parts. The first part, I'm just going to talk about the clinical utility and focusing more on the principles and the rationale behind the procedure itself, especially in the diagnostic workup and staging for lung cancer. And then I'll finish up with a bit of procedural considerations. And then after that, we'll give the floor back to the chairperson and my fellow great friends. Okay, so let's get started. So there are essentially two types of endobronchial ultrasound for those of you who are not so familiar with it. So there is the linear EBUS, also the convex probe EBUS, which is the same thing, as well as the radial EBUS, also sometimes called REBUS. So what are the indications for EBUS in pulmonology? So it can be summarized into the main 4 points. So first, the most important, right, would be the staging and restaging of lung cancer. Also, EBUS-TBNA can be used to sample centrally located tumors, and then also to evaluate intrathoracic mediastinal lymphadenopathy of unclear origin. And the final one, obviously, will lie within the domain of my good friend Ko, which is REBUS, using the radial ultrasound to sample the peripheral pulmonary nodule. So I cannot possibly overstate the importance of staging in lung cancer. So this is a very old study from the United States, which analyzed about more than 40,000 Medicare beneficiaries. So basically, what this study was trying to prove or show is that back in those days, more than 10 years ago in the United States of America, only 30% of patients with suspected lung cancer underwent bimodality staging. And only 5% had trimodality staging. So you'll be asking me, what is bimodality, trimodality? So single modality means that the patient only went for CT. Bimodality would mean either CT plus PET or CT plus invasive mediastinal staging. And then obviously trimodality would be the combination of everything, of all the three, right? So what is significant about this study is that as we utilize more modalities of staging, right, the patients actually have a lower risk of death, which is quite self-explanatory and instinctual if you think about it, right? Because the more staging, modalities we do, we are assuming that these are useful. And that means that they'll be more accurate, more thorough, right? And then that leads to the accurate staging and obviously the optimal treatment strategy for the patient, and ultimately impacts the prognosis of the patient in a good way. So what are the modalities of staging and restaging lung cancer? So generally, what this slide is trying to tell you is that, as you can see, right, we always start with a CT first, and then later, if we have the resources, maybe a PET CT, right? But as you can see, the utility or the sensitivity of all these radiographic modalities, right, in detecting nodal metastasis, which is what we are trying to, which is very important, right, in this staging of lung cancer, the nodal status, right? So the nodal status is extremely paramount, right? And you can see from the figures shown here that the CT and the PET are both, right, not that good, okay? The sensitivity is at 55% only in CT, and that is, we are taking CT criteria, right? Traditional cutoff of a lymph node enlargement as defined as at least 10 millimeters in short axis, right? And then the PET, right, outperformed the CT, but still not any better. The sensitivity is still only about 80%, right? And therefore, therein lies the importance of what we call invasive mediastinal staging. So what is invasive mediastinal staging in lung cancer, right? Very, very broadly speaking, right, it just constitutes either endoscopic methods or surgical, right? So the ones you see on the left-hand side will be the ones that are done by us, pulmonologists. So we used to do conventional TBNA for those of you who have done it before, but I think a lot of trainees, with the advent of the EBUS-TBNA, I don't think they have ever done a conventional. But there was a conventional TBNA, which we could puncture the lymph nodes using a Wang needle. And then obviously there are ultrasound guided needle aspiration methods, which would either be EBUS-TBNA or EUS, right? Endoscopic ultrasound needle aspiration done by the gastroenterologist and some pulmonologists. So sometimes if you see EUS-B, that is EUS done by a pulmonologist using a bronchoscope. Okay, and on the right-hand side, right, then traditionally, the medial stenoscopy is the gold standard for assessing nodal status, nodal metastasis in lung cancer. So obviously, the traditional one would be the cervical medial stenoscopy, but there are also variants like the parasternal medial stenotomy or Chamberlain's, or even extended cervical medial stenoscopy. And then for surgical methods, usually it would be VATS, thoracotomy, or more recently a transcervical lymphadenectomy. But you don't really need to know. But you just need to know that there are the invasive methods also vary in the degree of invasiveness. So EBUS-TBNA is now a very important tool to pulmonologists because number one, it offers access to all the lymph node stations that lie adjacent to the tracheobronchial tree, right? So obviously there are 14 stations of lymph nodes divided into 7 zones. Sounds like a complicated mess, but actually in real life, in clinical practice, very few stations are involved. And most of the stations can be accessed by EBUS-TBNA, right? The common ones that we are talking about would be the superior mediastinal lymph nodes, or the upper and the lower paratracheal lymph nodes, station 2, 4, the subcarinal 7, and then 10 and 11. So stations 5, 6, as you can see, stations 5, 6 all lie quite close to the aorta, right? And 8 and 9 further down along the esophagus. So they are not adjacent to the airway and therefore not accessible by this technique. So this is just, I think it was a review article published in Blue Journal. So what this is trying to emphasize to everyone is that sampling, right, must always be done in a I won't say systematic fashion. You should always start from the highest nodal station first, right? So sampling should always start from the contralateral side, right? The N3 lymph nodes, which are the contralateral mediastinal lymph nodes. And then obviously N2, which will be the ipsilateral mediastinal as well as subcarinal lymph nodes. And then the nodal ones, N1. And all lymph nodes, short axis of at least 5 millimeters should be sampled, right? So as you can see from this figure here, the image, the cancer is lying on the right-hand side. So you should start from the left, right? And then you just go up, yeah, and then across to the ipsilateral side. So anyway, this is just a video that we did that has been published in a book on IP recently. So anyway, what this is trying to tell you is that EBUS-TBNA is one of the more complicated procedures. Okay, although it's a diagnostic procedure, it is actually, in my opinion, much easier than doing rigid bronchoscopy, right? Because this is where your knowledge, right, your skills, right, and attitude, everything, okay, it has to come into one. You need to have to know the clinical presentation, what are you trying to do, right, and then you have to correlate, right, with anatomy, as well as radiology and then ultrasound in order for you to do a very good job in EBUS-TBNA. So I just feel that there leaves our general teaching and education in EBUS-TBNA leaves a lot to be desired. But I'm sure members of the audience will be doing something about it. Okay, anyway, this is just a video showing you that there's always a endoscopic correlate, okay, to your procedure, right? You should always try to get a view at the same time, rather than just focusing on the ultrasound. Okay, and then this is another video that uses another one of those technologies on the EBUS system, which employs the principle of elastography, right? Elastography is just a form of, as a modality that allows you to measure sort of like the stiffness, right? The stiffness of the lymph node. And this is especially important in sometimes, right, very, very aggressive cancers, or sometimes in, for example, mediastinal lymph nodes due to infections. There's a lot of necrosis, right? And then sometimes if you get necrosis of blood, it's going to be non-diagnostic. And therefore, using elastography is a good way of trying to determine the parts which are actually stiffer and probably would be able to generate the higher yield. Okay, so as we have mentioned earlier, so the gold standard, right, of mediastinal staging used to be mediastinoscopy, which is done by the surgeons in the OR, right? And this is a very old study already, but I think all of us should at least know, okay? This is called the Astor study, or subsequently called Astor 1, because there was an Astor 2 and an Astor 3 that followed, but the original Astor study was a European multi-center RCT, and basically they just randomized more than 200 patients, right, with suspected resectable NSCLC, and they're randomized to either receive surgical staging via mediastinoscopy or a combined EUS and EBUS, right? So this is combined using both needle aspiration methods. And the good thing about this study is that if the endosonographic methods yielded negative, right, all of them would undergo surgical staging. So basically, eventually everybody, right, went for surgical staging. Yep, so if they were tested positive in either group, right, they would then be considered N2 or N3 disease, which would be locally advanced, right, and then they underwent a multimodality treatment. And then those patients, obviously, if they did not have any mediastinal nodal metastasis after surgical staging, right, then they underwent thoracotomy with a complete lymph node dissection. So what were the results or the findings of this study? So as you can appreciate from the table, so surgical staging 118, right, and endosonography 123, right. So about 250 patients divided into two, right, and you can see that the endosonography by itself, the sensitivity was already higher than the than the surgical staging. But that was not the conclusion of the study, right? Because after a negative endosonography, they went on to do surgical staging, right? And you can see that the cumulative sensitivity, right, and the NPV, right, was in the region of over 90%. So what are the implications, right? The implications is that a staging strategy combining endosonography and surgical staging is still superior to surgical staging alone, right? Which is quite okay, and basically why? Because it has got a greater sensitivity and also led to fewer unnecessary thoracotomies, right? And in the 2013 guidelines, which is already 10 years old, and the ACCP guidelines, right? So they stated that in patients with a high suspicion of at least N2 or N3 nodal involvement, either by discrete mediastinal lymph node enlargement or PET uptake, a needle technique, right? You can use either, okay? They didn't specify, right? EUS alone or EUS or EBUS or combined EUS EBUS is recommended over surgical staging as a best first test, graded 1B, okay? And then following that, there was also a systematic review that was published in Lancet Respiratory Medicine about 6-7 years ago. Also found the same results. And so you have the endosonography, the sensitivity was 80%, and the MPV was 91%. So the thing is, you'll be asking, right? So do we need to do both, right? Do we need to do both? Because the studies are all doing combined, right? So obviously in this systematic review also had a subgroup kind of analysis. So basically what they did was that they compared the patients who underwent EUS first, okay? And then, or EBUS first. And then they wanted to ask, the investigators want to find out, right? What is the added utility of the second test, the second needle test, right? Depending on which was the first. So if you did EUS first, and then followed by EBUS, right? You increase your sensitivity by 0.22, right? And obviously this is like a screening test, right? In a way, in the same principle as a screening test, you have numbers needed to screen. In this case, you have numbers needed to test, okay? So it translated to a number needed to test of 14, right? So that means that for every 14 patients, right, you have, to detect one additional patient with mediastinal nodal metastasis would have been missed if only EUS was done, okay? And what about vice versa, right? So if you did EBUS first, and then you tried to do EUS, right? And you realize that the sensitivity, that additional sensitivity that EUS added to EBUS, right, was actually much, much less, right? And the NNT and the numbers needed to treat now was in the 20s, right, 25, right? Which is as good as PCI versus, thrombolysis, right? Which is actually a myth. Pulmonologists always say it's fake news. Yeah? So you can see that EUS, and therefore the conclusion is that EBUS-TBNA would be a reasonable option instead of combined endosonography. But obviously, then there will be people who will say that, yeah, then why don't we just do EUSB, right? But like I said, that's outside the scope of this lecture. And before I finish this part, it's a bit heavy, right? I want to go through some current controversies in mediastinal staging, all right? So do we need to do mediastinoscopy after an EBUS is proven negative, right? So the thing is, in the ESTER-1 study, which is the original study that we talked about, so the patients who actually had a negative combined endosonography, right, at detecting N2 metastasis, right, or mediastinal metastasis, nodal metastasis, about 9% of them actually had nodal mets at mediastinoscopy, all right? But the thing is, our diagnostic test, right, as we are taught, Bayesian theories, right, the issue is we always assume that the diagnostic performance of a test, right, is not dependent on the disease prevalence, right? We are talking about post-test probability and all those. Yes, yeah, we always have to talk about prevalence, which is pre-test probability. But unfortunately, in the real world, right, the diagnostic performance of a test really still depends on the disease prevalence. So for example, in the ASTER-1 study, you got a 9%, which sounds like a lot, and that's because 40% of them, 40% prevalence of nodal disease. But if you were to talk about in a population whereby you have already done, which has got a lower risk of nodal metastasis, like for example, in the ASTER-2 study, right, at 24%, then the issue is that your mediastinoscopy, that's going to pick up, right? Those people miss, right, by endosonography or needle methods would be much less, okay? There's a lot to digest, but just take it as it is, okay? As it is. That's the number one controversy. Number two is that we are also taught that central tumors, more than 3 centimeters, as well as N1, that means that nodal positive nodes in the hilar lymph nodes are generally risk factors, right, for N2 disease, because it sounds quite, the bigger, the more dangerous, right? Then if the N1 nodes are already affected, the more likely the N2 nodes are going to be affected, okay? This is our own logical deduction, okay? But I tell you the data, right, and this is still, we are still following guidelines saying that, if the tumors are small, they don't have N1 lymph nodes, we don't have to do EBUS, right? That is generally still taken as the truth. But let me just put it to you that the data is actually very unclear, because everybody seems to have a different idea of what tumor centrality is. So if you're going to ask your friends, the next one to you, just do a test, okay? Later, after the thing, just what is your definition of a central tumor? Okay? Everybody, I tell you one table, four or five of you, everyone's going to have a different answer. I'm quite sure. Yeah. So that is a real life problem, okay? Because of the study heterogeneity in terms of definition and methodology. Number 3. So we are saying that tumors, right, that are more than 3 centimeters, right, are they really more dangerous, right? Or rather, to put it in that way, if tumors are less than 3 centimeters, are they less dangerous, right? So it really depends. Like for example, in the older literature, right, the rate of unsuspected N2 disease in tumors more than 3 centimeters, right, and PET-CT did not show any hilar lymph nodes sliding up, right? The rate was only about up to 15%, okay? 6 to 15, right? So it's still less than 10%, maybe to some of us it may be acceptable, but newer literature actually suggests that it may be much more than that, right? So once again, it really boils down to the prevalence, right, of your N2 disease, right, in that group of cancer patients that they were dealing with, okay? So, and that's why it makes everything very complicated. Therefore, although generally we take the traditional accepted tumor size cutoff as 3 centimeters, right, just know that this is not really steeped in very solid evidence, all right? And then finally, same thing, okay, the N1 tumor thing. Okay, so I think you get the gist, okay? The idea is we are always taught that the only time you don't need to do an EBUS-TBNA is a peripheral tumor, less than 3 centimeters, right? And then there is no evidence of nodal N1 disease on PET, okay? You fulfill all this, right? You don't have to do EBUS-TBNA. But I'm just trying to tell you that I'm challenging that this may not always hold true, okay? And finally, this is just a motherhood slide to tell you that imaging, pathological evaluation, pulmonary function test, right? The staging process is potentially difficult and complex. Most of the time, it may not be, and that's why it's always good to have a multidisciplinary tumor meeting. So like in SGH, we have, thank God, we have a weekly tumor board, right? Tumor board. And all of us will be there. Interventional pulmonologists, radiologists, thoracic oncologists, PATH, everybody will be there, okay? So it's a team sport, right? And in order to get the best care for our patients, right, we really need everyone all hands on deck, all right? Okay, and then just to highlight the part. So we have talked about the utility of EBUS-TBNA in lung cancer staging, all right? I think the second part, which is the second point, which is sampling centrally located tumors that lie adjacent to the airways, I think that is the no-brainer. So let's not go there, all right? And then third, right, the third utility is obviously to evaluate intrathoracic lymphadenopathy, right? So you have mediastinal lymph nodes of unclear origin, right? And we know traditionally from existing data that the sensitivity and diagnostic yield may be a bit lower in cases which are non-malignant, right? As non-malignant is non-small cell lung cancer, all right? So like lymphoma, right, is especially challenging. Sarcoidosis, from the granuloma trial, you have about 80% diagnostic yield. So pulmonologists are always thinking of how to increase the diagnostic yield, right? So this is obviously something, EBUS, intranodal sampling, which I don't do, but Co does. So you need to find out from him, you can ask him, right? So there are methods to obtain bigger samples, right? Instead of the traditional needle aspiration, you are trying to get biopsies, right? So this can be either forceps biopsies, cryobiopsies, and obviously the data is still being generated, right? And the published data, right? Although the numbers are still small, and obviously there are reports coming out from Europe, the diagnostic yield is much more superior. But like I said, we'll have to await further data to make any, very concrete recommendations. Okay, and I'm going to finish up with the next 5 minutes. Okay, this is very simple. I'm going to talk about procedural considerations for EBUS-TBNA. All right. So first, for any to be a good procedurist, number one, you must know everything about why, right? Why you are doing the procedure and how does the procedure help you, and therefore you need to review the evidence as well as the gain and attain the necessary knowledge, right? And then the second part is all developing the skills and the techniques, which will obviously be better learned in hands-on fashion, right? But at the same time, there are also peri-procedural considerations, which is wisdom, right? Or sometimes just logic, common sense, right? That will help you increase your diagnostic yield and the success of your procedures. So in the current market, right, there are obviously various competing companies, right, producing different EBUS scopes, right? Even Olympus has got a new scope, not that new, but newer scope. So there's obviously Olympus, there's Fuji, there's Pentax, right? And the forward oblique view can vary from 10, 20, 35 to 45, right? So, but it doesn't really matter, right? As long as you are comfortable and you know how to use the scope. And also, different needles are being produced by different companies, right? So, different gauges and then different companies, right? So, we are going to review, right, whether all this, how all these things, right, would impact our procedure. So we're going to just go through questions for EBUS-TBNA, the procedure itself. Number one, the question would be, does the needle size matter? Number two, is suction needed or not? How many passes needed required at each site? And finally, is rapid on-site evaluation necessary? Okay, so does size matter? Okay. Anyway, in pulmonology, size doesn't seem to matter, right? Right, size of chest tubes for all this like pleural effusions or whatever, empyema is actually not proven to matter, right? And similarly, it's the same thing, right? So obviously, the Japanese have already tried to address this question. So there was a study, retrospective study by Nakajima that he evaluated 33 patients and he compared 21 gauge versus 22 gauge. So if you use the 21 gauge, which is a bit bigger, right, you get, in a sense, you get more tumor cells, right? But at the same time, this is offset by the fact that there was a lot more blood contamination. So that was the, give and take. And then Oki did a randomized controlled study of 60 patients, right? So also randomized, this is a proper randomized controlled study. What he found was that there was no difference, right, in terms of diagnostic yield, all right? So therefore, the ACCP guidelines recommended that in patients undergoing EBUS-TBNA, the use of either a 21 or 22 gauge needle is an acceptable option, right? Then obviously there are smaller gauge needles now, right? So I think there are still some, if you go through clinical trials.gov, there are quite a few that are comparing different brands or different sizes, but generally I think probably not going to be very significant. Okay, number two, the question is suction needed or not, right? And similarly, like in the plural studies, right, whether you want to suck or not for pneumothorax, you know, they were not going to impact. So obviously this was also another old study that randomized patients to either receiving suction during a needle TBNA procedure itself, right? Or you have this transbronchial needle capillary sampling, which is basically not really suction. So there was no difference in specimen adequacy or quality or diagnostic yield regardless of nodal size, right? And therefore, this is in the ACCP guidelines, they suggest that tissue sampling can be performed, right, either with or without suction, but this is an ungraded statement. And question number three, right, how many passes are you going to do at each site, right? So we as we have mentioned earlier, right, we go from N3, N2, N1. So how many passes should you do at each site, okay? So this is also another old study, right, 2008, but this was telling you, you know, the case of diminishing returns, right? And the more you do, yeah, there will be a ceiling effect. I mean, this is life, right? A lot of times. So as you can see from this study, right, once you do at least three, right, the fourth, right, or fifth, whatever, the additional benefit, right, is going to be very less. Is going to be very minute, right? And this also brings us to another point whereby, for example, in plural studies, right, plural fluid cytology, you send the first set, maybe diagnostic yield 60%, you send a second set, added 20%, by the time you send a third set, you know, the additional benefit of each subsequent procedure or test becomes less, right? So the optimal number of aspirations, at least three, right? And in that study also, if you had a core and a first and second aspiration, you may stop at 2, right? And therefore, the old guidelines, right, recommended a minimum of 3 separate needle passes, right? And also ungraded statement. But this was in 2008, right? So this was before the revolution in driver mutations and molecular analysis took place for lung cancer, right? So what about in this case, in this our current climate, right? How many sets are going to send, right? We need to ensure that there's adequate tissue material and specimens for all this NGS and FISH and SSTP, whatever test that you have, right? So this is also considered old, 10 years old, right? And back then, they only tested for EGFR, CRAS, and ALK, right? And back then, right, using a 21 needle gauge, right, 4 passes was considered enough to get enough enough material, right? But in this day and age, how many, right? How many do we need? I don't think we really know, right? But generally, I would do 4 to 5, and if I could, right, I would try to get the rows on board, right, to get specimen adequacy confirmation, right? Okay, and this was graded 1C, right? So this is a statement that is not a statement, right? They recommended additional samples beyond those needed to establish the diagnosis be obtained for molecular analysis.
Dr. Melvin?
Yeah.
You still have 1 minute left. Okay,
sorry, just finishing. Okay, and finally, is rows necessary? So this is just a table to tell you that there are pros and cons of rows, right? Rows, which is rapid on-site evaluation. So potential pros are, obviously, you could assess, right, on the spot, right, the adequacy assessment of the specimen, right, and maybe can improve your diagnostic yield, blah, 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 right? But the evidence is that there is no evidence that it improves diagnostic yield, adequacy assessment, whatever, okay? The only thing that it has been proven, I mean, in the literature, is that it reduces the number of additional procedures, all right? But at the same time, there are cons, right? Because it's time-consuming, manpower-consuming, blah, okay? And therefore, they also didn't make a statement that is really not a statement, with or without rows. And finally, this is just technical aspects of the EBUS-TBNA, which you can just get from CHESS in 2016, right? And there are about 10 statements, and most of them, half of them are ungraded, and the rest are like either 1C or 2C, right? And sorry for overrunning. Okay, thank you very much. Yeah. Thank you.
Yes. Thank you, Dr. Melvin, for your great and applicable presentation. Very inspiring. Then our next speaker is Dr. Shyang. Shyang, MD, MRCP, is an internal medicine physician and pulmonologist from Sarawak General Hospital, Kuching, Malaysia. Dr. Ko completed his primary medical training in 2010 and attained membership of Royal College of Physicians, MRCP, in 2014. He completed his National Respiratory Medicine Fellowship in 2021 and attained the European Respiratory Society Diploma in Adult Respiratory Medicine in the same year. Dr. Melvin will be presenting on EBUS Radial. So please welcome Dr. Shyang, and your time is 25 minutes. Thank you.
Thank you, Mr. Chairperson, for the kind introduction. Selamat siang. Saya dari jiran negara Malaysia. Bahasa saya teruk sangat. So please allow me to speak in English. So I'm from Sarawak. It's at the island of Borneo, next to Kalimantan. And I'm from Sarawak General Hospital. So this is the aerial view of my hospital located in the beautiful city of Kuching. So anytime you are free, you're always welcome to visit us. So I'll just touch briefly on radial EBUS procedure, its clinical applications, what's the benefits, and what's actually the limitation. So can I just have a quick show of hand? How many of you have exposed or have done radial EBUS? Okay, all right. So I'll try to tell you what is radial EBUS and why is it very helpful in my clinical practice. So this is the development history of radial EBUS. I think the main person is Professor Henry Becker from Heidelberg, Germany. So you can see initially how he used all the ultrasound monitor, and then how he created all the possible radial EBUS probe. And then this is his assistant. So the initial prototype is the radial probe with a balloon to examine the peribronchial structure. So this world first ultrasound probe, the Olympus UN-1W. You can see that it's actually a balloon radial probe. And the first transmission is from the thorax clinic for Heidelberg to Osaka during one of the World Congress of WABIP. So currently the radial EBUS setup is more simple. This is the radial EBUS in my hospital. So you can see this is the Olympus Xera 3 system. So this is what you have. The video system, the camera and the lighting, the light source. And then you have the ultrasound processor here, which is connected to a probe, and this probe will actually spin. Okay, and that gives you the ultrasound. So of course, I think other companies also have their radial EBUS system, the Pentax, but I have no personal experience on it. So if you look at the specs of this radial EBUS probe, there's really a lot of different sizes, balloon method, contact method, and whatever. But we really only have these two in the market currently, the 17S and the 20R probe. So I think when we talk about radial EBUS procedure, we really need to know about the size of our equipment, the working channel of our bronchoscope, and etc. So what's the radial probe scanning mechanism? We know that in the linear scanning ultrasound is due to the vibration of the piezoelectric crystal, and then it generates that ultrasound beam. So this is what happened in the convex probe EBUS. But in radial probe EBUS, this spinning mechanism, the transducer actually will give you that ultrasound image. I'm not too sure of the physics of it, but it's basically how it works. So it's 20 megahertz. And the scanning depth is 4 to 5 centimeters. So you have a very big tumor, you could not see the edge. So if the tumor is within 4 to 5 cm, then we can see the whole tumor easily. So the standard setup of radial EBUS is either with or without a guide shift. So this is a therapeutic scope with a guide shift there, and then you can see the radial probe coming out from the guide shift. So this guide shift allows you to extend your walking channel into the distally, wherever you want. And this is the ultra-thin bronchoscope. And this is the 17S radial EBUS probe, the smaller probe, which is not used in the guide shift. So why the scope is important in radial EBUS procedure? This is because we are talking about peripheral nodules. So we will need to know, we want to get to the nodule as near as possible. We don't want to do a long distance shooting. You know, we want to shoot someone, you want to go to in front of the patient, or I mean your target, and then you jab it. Okay, you don't want to shoot from far. So I think first we need to know your scope diameter, how far it can go. And then next you will need to know their walking channel. So how big the tools can go in your scope and this thing. So we have the therapeutic range scope, we have the diagnostic range scope, the P190, H190, ranging 4 to 5 millimeter, but 2 millimeter channel. And of course we have the ultra thin scope, which range from 3.8 to 3 millimeter, but we have to pay attention to the walking channel. So what is a guide shift? Guide shift is nothing fancy. It's basically just a plastic tube that charges a lot of $. So it's an empty plastic tube which you can insert into the bronchoscope, and then it will extend out from the bronchoscope for you to reach the target. So this again, I'll say, you know, I'll highlight the importance of the steering tools, which are bronchoscope and things like that. So let's say this is your airway and this is the target, and you have a lot of branches. So if you're using a big scope, you can only reach here. So it's very far from the target, and you need to navigate your way through all these branches. It's very difficult. So if you have a smaller scope, it gives you a better chance to reach there. A smaller one even better, and even smaller one even better, you can park in front. But of course, with a guide shift, you can reach there, you know, by some maneuvering. So basically, once you localize it, you would take out your radial EBUS probe, leaving the guide shift in place, and then you put in your forceps, cryoprobe, and whatever to biopsy the lesion. So what is I just want to emphasize a bit of guide shift because this is what everyone will be using. So the study from Nagoya recently shown that, you know, using a P190, a 4 millimeter scope with guide shift is associated with a better diagnostic yield. And of course, you know, your guide shift is not steerable, as in you cannot bend your guide shift or anything like that. So the one way to actually position the guide shift is to use the bidirectional guiding device, the QRET. I just want to show you a case. This is a case that we've done recently. There's a left upper lobe nodule, peripheral. So when we put in the radial EBUS probe, it keeps going down, you know, so you cannot bend, you know, we're using a big scope here, so you cannot bend the probe to go up because it's just impossible. So using the QRET, we can able to adjust the guide shift, and then we go into the lesion, and then we will leave the guide shift in place, and then we put the radial probe in, we get a nice image, and then we just biopsy, and this is a case of TB nodules. So standard radial EBUS examination, so you have a nodule here. So once you know where you want to go, we will just put in your radial EBUS probe into your target segment. I'll just fast forward this. Then this is the normal appearance of the lung as you advance your probe slowly. Slowly, you're adjusting, you know, you can't see anything. You still adjust, and then you're still adjusting. Sometimes it takes a bit of time. Then you see this solid lesion coming out, mixed echogenicity with a hyperechoic border. So this is the lung nodule that is shown on the CT. So you know your probe has reached the center of the lesion, and now we'll perform biopsy. So once I localize it, there will be a fluoroscopy to mark the position of my radial probe. This is what the radial probe shown. So this is roughly the area. So then after that, you will just take out the probe and put in the forceps or cryoprobe or whatever needles to get this. So I just want to spend a bit of time on these radial EBUS images because I think it might not be easy for everyone to interpret. But if you are, I think most of us are familiar with transthoracic ultrasound. So this is what you will have, you will see on a transthoracic ultrasound if you see free air. So the air node profile like pneumothorax. So this is similarly, if you do on the radial scanner, you will see very exaggerated airline. So these are free air. Okay, so if you compare them, it's not too difficult, just that one is linear, one is radial. So this normal lung parenchyma, snowstorm appearance, and then these normal airlines. Consolidation, you can see all these high density B lines. Again, on radial, you will see all these radiating out B lines. Consolidation, on ultrasound, you will see static air bronchogram. And then in radial, you will see all these dots and linear arches. So of course, mass, this hyperechoic border, this is what you will see in the radial EBUS. And sometimes when the target is very peripheral, we can actually see effusion with the radial probe. So this is the parietal pleura, this is the visceral pleura, this is a pleural effusion. So this is how it will look like. So it's basically just ultrasound. So also the radial EBUS image in relation to airway, because we cannot adjust the airway. The airway will be there, whatever they want. So if let's say the probe is within the center of the tumor, it will see something like that, which we call it concentric. If it's at the side, we call it eccentric. If it's just next to the airway, I mean next to the tumor, but not going into the tumor, it will be adjacent looking. Okay? So I think the Japanese have come out even further. They analyze how the pattern, all these things, and then they name it type 1, type 2, type 3, which I usually don't bother. But they have some diagnostic significance according to their study. So of course, if you have a ground glass nodule, they are, as you expected, ground glass nodule will not be picked up by ultrasound easily. But again, the Japanese seems to be able to see it with some blizzard sign, mixed blizzard sign. It's quite difficult. So we can also, through radial EBUS, we can actually examine the internal structure of the nodule. So you can see these are the solid nodules, but you can also see there are vessels that are surrounding that. So these are all correspondent CT. You can see these huge vessels here. So you can see the vessels, there's a vessel. So you might want to plan your biopsy a bit more careful. And very nicely, this is a case that we have, there's a cavitating nodule and there's a solid nodule, but all connected through one airway. So you can see when we put a radial EBUS probe, you can see the wall here. And then when you go into the nodule, the cavity itself, you see free air. And then when you advance the probe a bit further, you see this solid nodule again with pleural line. So the biopsy is metastatic NPC, unfortunately. So the clinical application of radial EBUS, or what I use it for, of course, it's for lung nodule. It's as a verification technique of our navigation to let us know that we are actually, at the nodule. But I also use it for a lot of other things. I use it for abscess drainage. I use it for examination of consolidation. I also sometimes use for mediastinal lesion. And then I also use for lung nodule without bronchus sign. But all these are not the conventional indication. Yeah. So this is a lung nodule with bronchus sign. If you can get your scope or guide shift into this target, you will get this kind of image, and you will just biopsy whatever you want. You could get the answer. So the Japanese have shown that if the CT bronchus sign is direct into the lesion or adjacent to the lesion, you have a very high diagnostic yield compared to lesion there's no airway. So if there's no airway, whatever we do, we can't actually get into it. This is a case that come to us, I think now almost 6 or 7 years back. There's a nodule here. When we do the EBUS examination, it looks like very round and homogeneous. And we just aspirate through the guide sheet, actually aspirated pus. So pre-biopsy, post-biopsy, and post-drainage, everything is gone. So it's a case of sort of abscess kind of thing, KPN on culture and treated and resolved. And sometimes we do not need to biopsy. This is a patient that clinically we suspect to have mucinous adeno-CA. So as suspected, when we put in the radial EBUS, you can see all this homogeneous density. We just aspirate through guide shift, and the cytology actually tells us it's a advanced mucinous adeno-CA of the lung. So it's very useful in my opinion. So this is a patient with an unresolved consolidation. So, I'll just do ultrasound. We can see this consolidation, and then we'll just put an EBUS probe in to check that you can see this consolidation. Biopsy is inflammation, and guide shift turned out to be streptococcus, and this patient is very well now. So for lung nodule without bronchus sign, you see, that's a bronchus here, that's the nodule. So when we put our radial EBUS probe, you can see this adjacently orientated lesion. Okay, so there's no way we can biopsy because there's no airway that's leading into it, and the mucosa looks normal. So what we do is we use a conventional TBNA needle. We just puncture to that side because we know that this side of the wall, the tumor is at that side of the wall. And then after that, we put in the radial EBUS probe to confirm it. And then we just took biopsy with forceps and biopsy. So mediastinal lesion rarely used because like what Melvin has mentioned just now, we usually use EBUS, but when sometimes your EBUS is down, it will be helpful. Because this is a huge 4R lymph node, we decided, we just do a conventional TBNA. So this is the Wang needle that Melvin mentioned just now. We just puncture through just by understanding anatomy. So we go into the 4R region, and then we do some jabbing. And then after that, I just put the radial probe inside. I confirm I'm there, I'm not in other place. Then I just proceed with biopsy. Yeah, so as you can see, the airway is very narrow here. So we decided to put in a stent as well, and patient able to go for treatment subsequently. So what are the benefits of radial EBUS? It have higher diagnostic yield compared to conventional unguided bronchoscopy. Lower complication rate versus CT guided biopsy. It allowed bilateral biopsy with quite a low risk in my opinion. It allowed us to do concurrent linear EBUS staging to mediastinum, and it also allowed concurrent lavage for TB and other infection analysis, which is very important in our region. So I think conventional unguided bronchoscopy, regardless with fluoro or without fluoro, the yield is unacceptable. It's less than 50%. This is in Sri Raj, a very good center in Thailand. Radial EBUS generally gives us around 70.6%. This is published in 2017, so it's quite long ago already. So CT-guided biopsy, I think everyone understands the risk, pneumothorax, but commonly quoted 25.3%, but those who really need chest still only 5%. So it doesn't mean that you don't do CT-guided biopsy. If you don't have other modality, you still go never just do it. But one thing we are quite concerned is this meta-analysis that come out, which show earlier pleural recurrence in early lung cancer, especially for young patient who underwent CT-guided biopsy for nodule. So potential pleural seeding, but of course this from meta-analysis. So now in our center, if this patient suspected early lung cancer, we will try not to do a CT-guided. We'll try to biopsy the nodule through radial EBUS as much as possible. So this is our unpublished data, our experience over 6 years. It takes the first batch, which is 100 of cases, the yield was very bad, 60%. So I think with cryobiopsy, with thin scope, our yield now is almost 86, 88%, with a risk pneumothorax only 1.1%. So I think it's really something that is very helpful. So bilateral targeted biopsy. So this is a patient with left upper lobe and right lower lobe lesion, clear mediastinum on CT and PET. So it allowed us to biopsy both sides, which turned out to be adeno-CA, one with EGFR, one without EGFR. So the tumor board decided that this is a synchronous early primary. So patient is planned for left upper lobe back, then a segmentect of the right lower lobe. Yeah. So there's no pneumothorax because it's all very guided procedure. So it allowed us to do concurrent mediastinal staging. So like this patient, a small nodule here, we get it squamous cell CA. Same setting, we just do the staging linear EBUS. So at one procedure, we diagnose and stage the patient. So the Korean group already shown that you can do this concurrent thing. Of course, the time is longer. You need higher dose of midafentanyl. There's no difference in complication rate. Importantly, we also do a very small audit. This is, I think, 5 years back. If we do this concurrent procedure, we can able to reduce our assessment time from the patient see us to the surgeon or oncologist to within a month. So we cut from 2 months to 1 month. So with this data in mind, although it takes us a bit long time, we will try to do it for the patient because we can really shorten the time of assessment. So it's not just about biopsy, we can still do targeted lavage. This is a nodule here, we can just put in the radial EBUS, we localize it, and then we can biopsy, and then we can do targeted lavage for gene expert and things like that, then we get tuberculosis. And cases like this, sputum FB, sputum gene expert negative from CT, I think everyone will agree this looks very much like TB, but again, there's no evidence. So with very targeted lavage, both sides at that segment, we can actually get it. And the Korean group, the Profiom, have actually shown that using a thin scope, guided by VBN and EBUS, increased the TB detection rate, the culture rate, as well, of course, the time of treatment initiation. So I think this is really quite helpful. So I think I've talked about all the goods. I think it's not a perfect tools. There's still a lot of limitation. It's just a verification tool. You still need some form of navigation, which I will talk more tomorrow. It's limited in ground glass nodule, limited in collapsed lung, because once collapsed, everything looks collapsed. And then, of course, the biopsy itself is not real time. So it's not a navigational tool. It's like you see the airway, the way which hole you want to poke, you don't know. Okay, so it's not a navigational tool. It's just a tool to confirm your navigation. So ground glass nodule, like I mentioned, is very difficult to see. So they are from the Shanghai team. They do a single arm CAT series by using cryobiopsy. They might increase the diagnostic yield until 82%. The Tokyo group also doing the propensity score analysis, cryo versus forceps, and it's shown that cryobiopsy might be better in GGO lesions with a very high odds ratio. I think the main problem of radial EBUS is atelectasis, especially in dependent segment like your B2, B6, 9, 10. Because you do under GA or patient is obese, usually they will collapse. So collapse is a big problem. So this is a case of mine in the RB10. So when I put my radial EBUS probe in, you see things like that, you know everything is collapsed. I don't know where is the nodule. So when I do biopsy blindly, it comes out to be collapsed alveolar tissue. But when we check at RB8, you can see normal aerated lung. So this is the main issue of radial EBUS. Especially if you do under general anesthesia, you need to do it fast. So of course, the US have come out with this VESPA trial. So they can compare LMA with FiO2 1.0 PIP0 compared to intubation, fast intubation followed by lung recruitment. They limit the FiO2 less than 1 with a high PIP at to 10. So of course, with this kind of ventilation strategy, they're able to reduce the atelectasis significantly. So this is something that we're looking into as well. So it's not a real-time biopsy. So I've shown you that once you localize it, we confirm through the radial imaging, then we actually retract out the thing, and then only we perform biopsy. So during that period, when we take out the probe and put in our biopsy tool, the guide ship can get deflected, your scope can get deflected, your patient's respiratory movement can dislodge our tools, or even sometimes you're fatigued, your hand is not stable, can deflect as well. So this is the latest toy in the market. I don't know how good it is, the ultrasound guided biopsy needle. So it's something that you can insert through your scope, and then this is the radial probe ultrasound. Then by looking at it, we can actually puncture, but I don't know what's the real utility of these new toys. Yeah. So the take-home message, radial EBUS is a useful tool in guided bronchoscopy. It's very useful in the diagnosis of peripheral pulmonary lesion. It's minimally invasive with low complication rate. And however, limitation of radial EBUS still persists, but which may resolve through parallel development of other technologies. So just allow me to advertise a bit. We are going to hold a EBUS and cryobiopsy workshop in Kuching in October. So you can scan the QR code just to follow us. We haven't opened the registration yet. So thank you from our team back in Kuching.
Thank you, Dr. Ko Shyang, for your comprehensive and insightful presentation. Very interesting. It inspired us to do the same thing in our hospital. And then the third speaker is Eric Daniel Tenda, MD, DIC, PhD. Dr. Eric Daniel Tenda is an internal medicine physician, pulmonologist from Dr. Cipto Mangunkusumo General Hospital, and also Medical Faculty Universitas Indonesia. Dr. Eric, medical doctor from Universitas Samratulangi, internal medicine specialist from Universitas Indonesia, fellow interventional pulmonology in Serdang Hospital, Malaysia, FUM, MC, the Netherlands, Royal Brampton Hospital, London, and PhD in interventional pulmonology from Imperial College London, and pulmonology and critical care consultant from Universitas Indonesia. And now he is a board member of World Association of Bronchology and International Pulmonology, Board of Region, and COI Committee. He will be presenting on emergency bronchoscopy. Dr. Eric, floor is yours. Your time, 25 minutes.
All right, good evening, everyone. It's evening already, is it? No. All right. It's actually a bit hard to talk after the two giants from Singapore and Malaysia, right? I mean, once again, thank you very much, and give a round of applause to Melvin and Dr. Cole. They're my two best friends. I think we spend most of the time together during conference, having coffee instead of going to the sessions, correct? So I think this is the first time the three of us to have a sit down together and listen to our talk. So the topic of this session is actually a masterclass in interventional pulmonology. So the thing that you need to master is not my topic actually, because I think this is a basic knowledge for everyone, especially for those who perform interventional pulmonology procedures. So there are two main topics that actually you need to master, which is EBUS-TBNA by Dr. Melvin and Radial EBUS. But again, to complete the misery for today's sessions, so let me elaborate more about emergency bronchoscopy. So Dr. Ko already asked everyone if there's any one of you perform radial EBUS. I know in Indonesia, Dr. Ko, we only have one radial EBUS, and the radial EBUS is only at the National Hospital, which is at my hospital. So probably this is still quite a new procedure to all the attendees here. But again, if I can ask a question, is there anyone here beside Dr. Mira, Dr. Harry, Dr. Erika, anyone here performing atau bikin bronchoscopy? Ada dong, atau yang udah pernah belajar bronchoscopy? Oke, alright. Kurang lebih ada 2,000 lah ya. Oke, banyak banget. So, let me elaborate more about emergency bronchoscopy dan apa yang kemudian perlu diketahui. This is my disclosure. Alright, so my talk will divide in two parts. The first one is I will take a time, please allow me to have some time to actually hoping to inspire everyone to become a consultant in pulmonology and critical care, internal medicine specialist definitely. And then I will walk through every one of you with, which is my topic for today, which is emergency bronchoscopy. So this is the training. Again, this is out of my topic, right? But I just want to introduce to everyone here, probably we still have medical students or general practitioners or the undecided group, whether they want to be a pediatrician, they want to be a surgeon, but I would like to introduce interventional pulmonology training in Indonesia. So again, interventional pulmonology is actually provides you a minimal invasive procedures to actually do some magical things like what mentioned by Dr. Ko and Dr. Melvin. This is a combination of medical field that give you a gift to actually not only understand the physical examinations, patient's history, proper laboratory interpretations and radiology interpretations, but also it can give you an expertise to do a procedure. Not many of internal medicine specialists can actually have this kind of benefit to do a proper or a comprehensive treatment to a patient. So that's why interventional pulmonology is very interesting to me. So this is the development of interventional pulmonology training. There are certain numbers that actually required to do a certain procedures, like for EBUS-TBNA or radial EBUS or airway stenting, rigid bronchoscopy, right? So this is the numbers from US and Europe. So let's say if you want to master rigid bronchoscopy, during your training, you need to achieve or at least perform 50 cases, right? Europe, 20 for thoracoscopy or pleuroscopy. In Europe, during a training, 10 kasus saja, tapi kalau misalnya di US 20. Nah, ini kurang lebih minimum requirement-nya. Alright? So again, why interventional pulmonology is very linked to internal medicine. So this is back on the original curriculum of internal medicine. Before we start our career as a consultant of pulmonology and critical care, you need to finish your internal medicine training first. Alright? So this is very basic. Otherwise, you cannot treat or you cannot perform a proper interventional pulmonology procedures. as what Professor Atuf Mehta mentioned on his Twitter a few months back, before you become a pulmonologist, you need to become an internist. Before you become an interventional pulmonologist, you need to become a pulmonologist. So that's how we need to properly understand about this. I know ini lagi marak banget kan di mana aja gitu ya mengenai kurikulum pendidikan gitu. Tapi ini yang kemudian dirujuk dari apa yang kemudian saya quote dari Royal College of Physicians di UK. Oke, saya mungkin bisa langsung aja ya Dr. Thomas karena pasti setelah ini diikut sama Dr. Thomas. Oke, so kurang lebih itu yang kemudian ada mengenai intervensi pulmonologi. And again, to get this set of skills to do interventional pulmonology training, we are more than happy to welcome every one of you who want to register as a fellow atau SP2 di pulmonologi dan medikritis. Banyak center yang udah buka gitu ya di Indonesia. Let's move forward with emergency bronchoscopy. So this is very interesting. This is kita main kasus aja gitu ya. Tapi before we start with the case for today, so these are the statements that released by ERS and ATS about interventional pulmonology. So there are two groups. The first one is the group with the already clear value of diagnostic bronchoscopy, while group 2, not clear evidence, whether there's a consensus about the timing for its performance, I mean, in terms of bronchoscopy. So where the emergency in bronchoscopy falls off, whether in group 1 or group 2, again, in group 1, we see there's a thoracic trauma when there's a suspect of airway obstruction, like blood clots, foreign bodies, secretions, or airway rupture. While in group 2, patients with hemoptysis. Saya yakin pasti banyak dokter yang kemudian di IGD sering ngalamin atau nemuin kasus seperti ini gitu ya. Dan ini kemudian merupakan salah satu indikasi di mana kita dapat melakukan emergency bronchoscopy. So these are the indications for emergency bronchoscopy. First, mostly we see patients with airway hemorrhage, atelectasis due to mucus retention, airway foreign bodies or airway stenosis, tracheobronchomalacia, patients who's difficult to intubate, and pulmonary edema or ARDS. All right, are you ready for today? I'm going to play a game. Probably some of you already very familiar with my slides, but let's play a case, all right? Okay, let's come back. Inhale, all right? We're ready. We're going to enter the emergency room, all right? There you go. All right, this is the situations. So sorry, this case is in Bahasa. I hope Ko will translate it to Melvin. But again, this is a man, 55 years old, with a chief complaint of coughing blood since 45 minutes before admission. So he's coughing blood, about half a bottle, and then there's a dyspnea, chest discomfort. The patients with a past history of smoking for 40 years. Patients also diagnosed with late-stage renal disease. Also diabetes. From the physical examinations, the blood pressure is 90/60, tachycardic, and then no breath sounds on the on your right lung. The hemoglobin level is 7, leukocytes 11,000. And platelets 150. All right, so what should I do? Anyone? Berdoa? Pasti ya. All right, so let's see, let's meet the patient. First, before we actually experience this kind of situations, right? Before our daily practice, what we need to do is we need to be fully trained and always prepared for something bad that will happen during our shift. All right? So first, be prepared, which means you need to train your staff. Not only train your staff, but you need to train yourself as well, right? As a doctor. To be able to control the bleeding, if the case are bleeding, right? Or airway hemorrhage. Again, train the staff, prepare the equipment, and also the drugs that needed to do an emergency bronchoscopy. Secondly, ABC is standard procedures in emergency departments, so don't forget to do a proper assessment of airway, breathing, and circulation. And then, once you have a proper assessment of the ABC of the patients, then you can call for help. First one, anesthesiologist. You want to make a good friends with our anesthesiologists. Don't forget about them. ICU, thoracic surgeon, and of course, interventional radiology. And all of these points I learned from my ex-boss, with forever boss, Professor Shyang, right? So next slide. So let's say you guys already do the bronchoscopy, and this is what you found during your scope. All right? I'll play again. Oh. Oh. Can we play the video again? Oh. Okay. All right. So here we can see there's a giant blood clot sitting peacefully, looking very beautiful in red in the main array. So what should I do? What you guys will do? Mau ngapain, Dok? Berdoa lagi pasti. Selain itu, apa lagi? Nggak konsul Dr. Eri. Okay, first, make sure before you shift, do prepare your equipment. Second one, make sure your team is ready and really understand about every step while doing an emergency bronchoscopy. While you're performing emergency bronchoscopy and you see a red screen, right? What first thing that you need to do is suction. Okay? Do suction and suction and suction. I have experienced probably one or two of my fellows and residents when they see a red screen, they have an urge to take out the scope, right? So please do suctions first, okay? And then before you perform any emergency bronchoscopy, make sure you have a good communications with your nurses. So then you can communicate with them. Please prepare the cold saline. All right. So after suction, if it's still red screen, give cold saline. All right. And then after that, suction and suction. And the most important thing, as a leader of the group, as a leader of the pack, you're the interventional pulmonologist, you need to stay calm. All right. If you panic, everyone will panic. Even the patient is already sedated, he will also panic. All right. So please stay calm, even though your heart almost fell off, right? But again, do stay calm. Sometimes I don't calm as well, but again, stay calm. It's always best to do emergency bronchoscopy through your rigid scope, right? To make sure the patency of the airway. All right, so for the cold saline, again, you can just give about 50 mils aliquots of cold saline where the suhunya sekitar 4 derajat Celcius. So jadi dokter bisa store itu di kulkas. Setiap kali ada emergency bronchoscopy, jangan lupa bawa NaCl dingin, gitu ya. Okay. Next, it's still red screen. What should I do? Apa dok? Silahkan dok. Apa kira-kira? Masih merah nih. Kita keluarin scope-nya atau enggak? Do we need to take out the scope? It's still red screen. You already pray very hard. Come on, why still red? Why? Dr. Eric lagi cuti. Dr. Mira dan Dr. Harry juga. So, konsul kepala divisi, Dr. Gurmit. So what should I do? So again, remain calm, communicate with your nursing staff, make sure the emergency trolley are close to you guys, all right? Because sometimes you need an emergency medications, and keep do suctioning. So suction, 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 suctions until you can properly see the screen, all right? There's always a place to give adrenaline, right? So you can give adrenaline 1 in 100,000, 2 to 5 mils aliquots, right? Atropine can also be used, and also ice cold saline as well. And then after that, if you still see a red screen, do suction again. But the most important thing, why I keep saying all of this, is please, if you still see a red screen, do not ever remove the scope. Don't. Ko and Melvin will not be very happy if you remove the scope. Alright? So do not remove the scope. Jadi jangan dikeluarin ya dok, scope-nya kalau lagi perdarahan. Jadi dokter suction terus, kasih NaCl, kasih adrenalin, sampai kemudian bisa clear betul, baru kemudian boleh kemudian dokter misalnya mau evaluasi hal yang lain. Tapi jangan sekali-kali mengeluarkan scope ketika di dalamnya itu si bronkus masih merah gitu. Atau screen-nya masih merah, bukan apa-apa yang merah karena perdarahan. Alright? So you can also perform, don't see the stand, but you can also perform the rigid bronchoscopy. So what should I do next? Again, keep calm. You can always do the intubation to the patients, and there's always a place to, there's always a way to place a balloon blocker, right? Balloon blocker will be very beneficial in conditions like this. All right, this is how you're going to position your balloon blocker side by side, so you can actually localize the airway bleeding, right? Kita nggak mau perdarahannya pindah dari satu paru ke paru yang lain gitu. So, jadi paling baik melakukan hal seperti ini. Demikian juga apa yang dilakukan tadi sama Dr. Go tentang radial EBUS. Sometimes when we do a radial EBUS and then we're gonna do a cryobiopsy, we need a balloon blocker. Kurang lebih seperti itu ya dok ya tekniknya. Jadi kita mau localize supaya perdarahannya tetap di situ aja, gitu ya. Okay. Again, if you still see a red screen, do not ever remove the scope. Okay. So do I have another options? Yes, you guys have another options. There are a few options for treatment strategy, especially for patients with airway hemorrhage. Beside cold saline, you can do endobronchial stent placement and also coagulations, right? And argon plasma, if you have argon plasma, do argon plasma coagulations. And we're going to learn more about argon plasma coagulations after this session during the workshop. So this is what happened during the case. So as I mentioned, this is patients with central airway obstruction who required an emergency bronchoscopy. There's a giant blood clot sit peacefully inside the trachea. So you need to be able to remove the giant blood clot, right? Control the bleeding. So then the anesthesiologist can intubate the patients. So in this case, I actually combine few techniques. So I remove the giant blood clot that caused the central airway obstructions with cryo extractions. And then to control the bleeding, you can use, again, normal ice cold saline, adrenaline, and if you need argon plasma coagulation, that can also be used. Right, so this is the results after we do emergency bronchoscopy for that case, the one that I just presented. All right, this argon plasma coagulation, it can also be used to control the bleeding in the airway. Right, so this is a non-contact procedures. Yeah? All right. So we actually published this case report, and this is one of the first two case report which combines cryo technique and ATC. So this is the algorithm for patients who experience a massive hemoptysis. So again, what we need to always remember, keep calm because you are the leader of the pack. You need to look very peaceful, even though you probably almost fainted. But again, be calm, be prepared, do the drills, even though that you don't have anything that day, but schedule a drill so that everyone knows how to work in emergency situations, right? The drill will include, you need to have your ice cold saline always stored in your fridge, all right? Adrenaline is important. And of course, the prophylactic measures like endotracheal tube, balloon blockers are very important to maintain patients with airway hemorrhage. So I think that's all with my presentation. I hope everyone can learn how to do an emergency bronchoscopy. Again, thank you very much, and I'm hoping to get more questions from everyone. Thank you.
For your applicable presentation, yeah, it's very useful when we perform bronchoscopy. And then this session is hybrid symposium, so that for online participants, you can type your questions in the chat box. And you can share your experience, daily activities in the field as a medical doctor or internal medicine specialist or pulmonologist. And also, we ask to the audience to answer the questions for the speaker. And then I ask 3 speakers to come up in the stage, Dr. Melvin, Dr. Eric, and Dr. Ko, so that we can share together, discussing together about the interesting thing, interventional pulmonology. Okay, any volunteer to ask to the 3 international speaker, yeah? Okay, yeah.
Thank you, Dr. Thomas. So I think this is a great topic, I think. And I have question to Dr. Ko, or maybe to 3 speakers. Dr. Ko, the first one, if we don't have no bronchus sign, how we do appropriate biopsy to the patient? And the number 2, if for eccentric nodule, how we know that our needle will get the nodule? Thank you.
Thank you, Dr. Heri.
Thank you for the question. So the first question is how do we biopsy a nodule without bronchus sign? That's correct. Okay. I think nodule without bronchus signs. I think first thing is how to analyze the CT properly. So a lot of time I think there will be a bronchus leading to it. Maybe it's too small, or sometimes if it's from the PET scan when the patient didn't take a deep inhalation, so the airway might not be visible, or if it's expiration CT or things like that. So yeah, so I think first is to look at the CT really properly to see whether there's any airway or not. So second I would do is, usually as we know the secondary pulmonary lobule, the pulmonary artery usually follow the airway, while the pulmonary vein actually can go on the interlobular septum. So if you see a pulmonary artery that actually follow the airway, I mean, when you cannot see the airway, but you actually see a vessel leading to that nodule, and when you trace back that vessel, it's actually a branch of a pulmonary artery. There is a good chance that there is an airway if you are trying to do the procedure. So of course, if there's really no airway, I think bronchoscopically there are a few other ways to biopsy, which I'll talk about tomorrow when we talk about interventional approach to nodules. There are transparenchymal approach and things like that with now robotic platform, which is doable. But of course, if really cannot, CT guided biopsy is always possible. Second question is eccentric nodule. If you are putting in the needle, how do you know the direction? So I think it's difficult. It's very difficult. I think I have asked some of the overseas experts. They say, well, it's difficult. It's based on your judgment and things like that. So I think the needle that I showed you just now, the last slide, that actually allowed real-time visualization, and you can actually rotate the needle, rotate the EBUS to have a real-time visualization of the needle going into the nodule, the INOTS needle. So that might help, but again, it's a big instrument. Whether it will reduce the flexibility of your scope, etc., we still don't know about that. Yeah. So of course, I think you can use fluoroscope to guide. But again, it's a 2D image. It might be difficult. You might use COMBEAM or those things, but I think it's difficult. Yeah. Melvin?
Dr. Heri, do you have any comment? Okay, enough. Okay, the others questions? Yeah.
Okay, thank you very much for the opportunities. Firstly, I would like to thank you for a very excellent presentation from all the speakers, and My name is Albert from East Nusa Tenggara, and I would like to ask about, actually, this is from Dr. Melvin Tai. You have mentioned before about in the Lancet Respiratory Medicine that the analysis from the subgroup analysis, you divide it two. So the first one, the group use the EUS and then continue to EBUS, and then the second group EBUS first, then continued by EUS. And actually this is my curiosity, like I don't know, like according to your analysis, like what kind of factors that affect the sensitivity and also the number needed to treat, because both are the same procedures but different order. Yeah, that's the question. Thank you very much.
Yeah, thank you very much. That's a very good question. So that, in order to answer that question, we must understand that the esophagus, right, is a left-sided structure. So the esophagus, depending on the patient's anatomy, although I've also attended conferences with gastroenterologists who say that EUS can do everything, okay? Their claim, okay? But obviously it's not very based on evidence, right? But I presented the same data and, people were not very convinced. But we all know that EUS can target the left-sided, maybe 2, 4, sometimes they say if you're very lucky, maybe 5, 7. And obviously those lying along the esophagus, right? And obviously 8 and 9, those we have already set. But on the right-hand side, right, it may not be so easy, right? And therefore, that's why I say it just happens because we're dealing with lung cancer, right? And then the nodal metastases are all around, most of the time, clinically significant ones are all around the tracheobronchial tree. And that gives us advantage. So if to put it in a non-politically correct way, right, EBUS is really a better first tool, right, of a needle method, right? But obviously, the guidelines have avoided saying which one, right? Just now, even ACCP will say you can choose a needle method as a first best test, but they did not say, you can use EUS, NA, EBUS, or whatever, right? But like I said, if you base it on evidence, right, obviously EBUS is a better first test, definitely, yeah. And that's why the numbers needed to test, right, which means the number of patients that if you do it alone, right, you potentially miss an N2 disease, right, is going to be much more if you just do, what do you call that? It's going to be much more if you do it in EUS alone. Yeah, thank you. Yeah.
Okay, that's enough. Okay. And then from online, yeah, questions. EBUS-TBNA in a patient with more than one mediastinal lymph node enlargement, should we go sampling for all lymph nodes? Maybe this question for EBUS-TBNA.
Yeah, so that's also a very relevant question. So the most important thing is to, number one, always do the highest stage lymph node first, right? So we always do N3, N2. By the time it hits N1, it may not be so important, right? So I think more importantly is just that we are targeting nodal disease, right? So mediastinal nodal disease, N2, N3, we have to exclude it, right? And therefore, we should always sample the lymph nodes. Another question that has been put forth, right, just to build on this, is that there are different approaches. So there is a targeted there's a targeted approach whereby, based on your CT and your PET, right, you just go straight to the lymph node of concern. But then there are also the other camp, right, which would say that you should do a systematic review. And that means that you have to do all the N3 lymph nodes and N2 and N1, whatever. But even if you look at the studies, I think there was a recent, not too long ago, published in the, I think, European Respiratory Journal. The problem is, right, even their definition of a systematic lymph node assessment, right, is not complete, right? They only do station 4, 7, maybe 10, 11. There's no 2, right? So therein lies the constant debate. But for me, generally, because we don't do it under general anesthesia, you know, the Europeans or whatever, the patient is like being gassed the entire time, right? You can actually take your own sweet time and go and do. But for us, you know, there is moderate sedation, conscious sedation. It makes it more difficult, but I still try to do as complete a systematic ultrasound, right? Because it's actually pretty quick if you are sort of familiar with it. Yeah. But there's no right answer for that. Yeah.
Maybe Dr. Ko or Dr. Eric, any other comment? Any addition, Dr. Eric?
Sorry, Melvin, I'm not. I'm just gonna add some more information, especially for us in Indonesia. I think this is a very good question because one of the caveats, if you guys already read one of the publications, it was back in early 2010 or 2012 from ATS. So jadi kalau ada pembesaran kelenjar getah bening di CT scan, jangan pernah sekali-sekali kemudian mengkonklusikan bahwa ini part dari malignancy. So, jadi pertanyaannya kemudian, should we go sampling for our lymph node? Buat saya itu enlightenment gitu ya, bagus karena kita tahu bahwa ada pembesaran kelenjar getah bening, so we need to sample. Nah itu sih, saya senangnya itu pertanyaannya gitu, karena kita tahu bahwa kalau misalnya ada pembesaran kelenjar getah bening, it's always best to sample. Jangan sekali-kali kemudian bilang, oh ini ada karena, because there's a mass at the left upper lobe. So if we found any mediastinal lymph node, enlargement of mediastinal lymph node, this could be part of the malignancies. So again, to have those kind of questions like this is very good because you know what is the best way to actually do a proper staging in patients with lung cancer.
Yeah, maybe just one point. I think what Melvin and Eric mentioned is if we are doing linear EBUS for staging purposes, then you should try to sample as much as possible from N3 to N1. But if your indication is not staging, you are just biopsy for a huge lymph node of unknown origin, you know, the isolated mediastinal hilar lymph node, then of course you select the most juicy one and just biopsy and get it. Then in that situation, you might not need to biopsy all. But in staging, yes. Diagnostic, probably not. Yeah.
Okay, because of the limited time, so that I will conclude the session, the fifth session. EBUS-TBNA is innovative procedure in a diagnosis of both malignant and benign procedure. And radial EBUS is useful procedure in bronchoscopy. And radial EBUS is very useful in diagnosis in peripheral pulmonary lesions and minimal invasive with low complication rate. And thank you for your active participations and valuable contribution today. Your insights have made this session engaging and informative. I want to thank each of our speakers and participants for your valuable contributions. We appreciate your time and effort in making this symposium a success. And thank you also for my gratitude to the organizing committee, volunteer and sponsor for your support in making this event possible and success. Thank you very much.